IT 292. We're looking at healthcare reimbursements. This is now week 3. And for the next several weeks, we are going to be focusing on chapter 2 in our book. So I'm going to do slides 1 through 22 in this lecture. And we will actually use these over the next a couple of weeks. And then I will finish off chapter 2, the last 6 slides of chapter 2 in week 5. And then from there, we will finish chapter 2, and starting week 8, we will be on chapter 3. So just kind of give you something to be aware of. Here we go. We are studying Principles of Healthcare Reimbursement, 6th edition by Ann Casto. We are now moving forward into clinical coding and coding compliance. And what I'm going to talk to you about today is clinical coding. We're going to save coding compliance because that's the last handful of slides in this deck for 2 weeks from now. Our learning objectives are here for you in our syllabus. They are 9.11 through 9.19, as well as 9.12, and that is for week 3. And then that also is week 4 as well. So we're going to talk about HIPAA. I'm sure you've talked about HIPAA before, but we're going to talk about it again, and we'll talk about it again and again and again, because HIPAA has so much to it, and it impacts almost every aspect of health information technology and management. So those are our learning objectives. Let's talk about code sets. They are used to communicate health status and services from providers to third-party payers. They allow for consistent communication. Code sets are used by these third-party payers to determine reimbursement for services and procedures. They allow for efficient payment processes and processing. Code sets are used to transmit health services and are standardized by HIPAA. The HIPAA legislation from 1996 standardized code sets and said that there's basically these approved code sets, and that is what every covered entity has to use. At the time in 1996, it was ICD-9, and in 2015, third quarter of 2015, that moved to ICD-10, CM, and then they added PCS, which was new. HCPCS coding system has been around for ages. It's a blend of CPT and HCPCS level 2, and that continues to evolve as well. I apologize for the cat meowing in the background. She's fine. She just wants to go outside. She'll have to wait. HIM professionals must have a baseline understanding of code sets in order to understand Medicare prospective payment systems. And facilities and physicians have to comply with guidelines, or they're supposed to comply with guidelines. Let's put it that way. They're supposed to comply with guidelines and conventions published for the approved code sets. And when they don't, that is when the Office of the Inspector General gets involved and we start talking about fraud and abuse. And so that's why compliance is a part of this that we will talk about in a couple of weeks. And we need to make sure that we are receiving accurate reimbursement, that we're asking for and receiving accurate reimbursement. Okay, so ICD stands for International Classification of Diseases. So make sure you know what ICD stands for. ICD itself is maintained by the World Health Organization, or WHO. It is used throughout the world for mortality reporting. It is updated approximately every 10 years, sometimes sooner than that. The whole world went to ICD-10 before the United States did. We were one of the very last places on earth to move to ICD-10. ICD-11 has already been released. They are working on that, and I wouldn't be surprised if that comes to the United States here in the next few years. But for now, we have ICD-10, and that's what we need to focus on. That's our current version of ICD that we use here. So ICD-10 is the most current version that we are using in the United States, and it has been clinically modified for the United States. That's what the CM means, is clinical modification. Around the world, there are a lot of countries still using ICD-10, and there are some that are just starting with ICD-11. ICD-10 is used by the CDC for acute illness and mortality reporting. And as I said, a lot of other countries have been using ICD-10 lots longer than we have. ICD-10-CM, that's that clinical modification that took place for us specifically here in the United States. And those modifications are made by the National Center for Health Statistics, NCHS. And they expand ICD-10 to include morbidity and chronic conditions. It is used to report diagnoses in all healthcare settings, all long-term care, hospice, substance abuse, behavioral health, outpatient, inpatient, freestanding EDs, ambulatory surgery centers. Everybody uses ICD-10-CM for diagnosis reporting. That's good old HIPAA. So hopefully by now you have already had an ICD-10-CM coding class with Miss Shelley Grant. She is awesome and she is a wonderful teacher, and I am so glad to work with her. Anyway, she has probably already taught you about category codes, subcategory codes, and how you get to your final ICD-10-CM code. So I am not going to linger over it here because I know she has already done that. Moving on. Again, ICD-10-PCS, I'm sure you learned this from Shelley as well. It was developed in the US to report inpatient procedures. All right, let's stop there. Inpatient procedures. If it's not an inpatient procedure, you do not use ICD-10-PCS to code it. If it is an outpatient, observation, ambulatory surgery, that is all CPT and or HCPCS, depending on the situation. PCS was first rolled out October 1st of 2015, that third quarter of 2015. It is a unique methodology and code structure for reporting procedures. It's different from the rest of the world. And love it or hate it, there are people on both sides of the fence. It is what it is. And this is just a good overview of a page in that. It talks about the section, the body system, operation, body part, approach, device, and qualifier. It's 7 characters. You know, so yeah, I'm not going to go into detail because you should have already learned this, but it's a good reminder. All right, ICD-10-CM and PCS, what are the uses? Why did they develop it? Well, it's for morbidity and mortality reporting for statistics. ICD-9 was not as specific as it needed to be, and they were running out of ways to expand it, to add new technology, new procedures, new diagnoses, new syndromes that had been identified over time. And so they needed something that was bigger, more flexible, had more chances to add things to it, and was a little more standardized than ICD-9, specifically for morbidity, more so than mortality. And so that's really what the push was behind that. It's used to classify diagnoses and procedures for research, index records by disease and surgical procedure, report information for healthcare reimbursement systems, analyze resource consumption patterns, analyze the adequacy of reimbursement, and quality metrics. Develop and report and analyze quality metrics. Reimbursement methodology examples. There is the prospective payment of MSDRGs, Medicare Severity Diagnosis Related Groups. There are case mix groups, and that's in hospital rehab. For home health care, there are home health resource groups, HHRGs. Who maintains ICD-10-CM and PCS? That is the Coordination and Maintenance Committee. NCHS maintains CM. CMS maintains PCS. And I don't know any easy way around this except memorizing that. And odds are you won't need to know a whole lot about that, but try and at least attempt to keep that in the back of your mind. Guidelines for each of these are posted on the CMS and NCHS websites. And they're, you know, it's the coding guidelines, the national ones. And then you have many codebook publishers that include those in their code books or their electronic code books, because there's not very many paper coding books left anymore. Everything is more electronic, online, and coder basis. Okay, who advises about changes to these? Well, there's cooperating parties. NCHS, CMS, AHIMA, and AHA all work together, and they develop the changes that are going to be going forward and the advice to clarify those. And that comes with coding clinics that are published quarterly for both CM and PCS. And make sure that you stay up on that, because they try to get into some of the more vague or unclear aspects of CM and PCS coding. Excuse me. They want to clarify those so that we are coding those consistently. And so on a quarterly basis, they release their advice, which is official guidelines for how you're supposed to do things. And that's where they do that. You can actually submit questions to Coding Clinic and ask them to clarify things. I've done that before. That something comes up and it's just not clear. There's not an old Coding Clinic that addresses it. It's not involved in the guidelines. Maybe you're getting conflicting information from payers about what they expect or what they demand. You can always go to Coding Clinic, email them, and put your question in, and they may choose to address it. HCPCS. HCPCS are Healthcare Common Procedure Coding System, and there are 2 levels of those. Level 1 is CPT codes, and level 2 are the actual HCPCS codes themselves. And again, I'm sure Shelley has gone over this with you, so I'm not going to spend a whole lot of time on it. CPT reports diagnostic and surgical procedures and services for outpatient procedures. Outpatient procedures, and also for the physician billing side of life and the facility billing side of life. They were created and published by the American Medical Association, AMA, in 1966, so they have been around a long time and been through many iterations. The 4th version, CPT-4, has been around for quite a long time, and that is what we continue to use. HCPCS came into being in 1985, and that was primarily for Medicare reporting. So CPT, when is it used by physicians? It's used for their inpatient services and procedures when it's for an inpatient type service. So for instance, if you have a physician who comes in and does a history and physical on a patient, they will have a CPT code that they will bill for their service. But the hospital information itself will all be ICD-10-CM and ICD-10 PCS if there's a procedure. And when the doctor is billing his diagnoses will all be ICD-10-CM, but his service to that patient for like the history and physical or the discharge or a consultation while they're hospitalized will all be using a CPT code. Ambulatory surgery services and procedures, emergency department services and procedures, outpatient services, procedures, office services, procedures, that's all CPT. Facilities use it for anything outpatient for services and procedures as well, for whether you're talking ambulatory surgery, emergency department, or clinic. Category 1, those are services and procedures. That's your typical, what you're used to of your traditional CPT. They're 5-digit codes, and they give you an example here of a complex repair on the trunk. The next one is category 2. These are data collection codes. These are 5-character alphanumeric codes that have F at the end. The letter F is in Friday. Let's say Friday, because everybody likes Fridays. So just remember that that's a data collection type thing. Category 3 codes are new technology. These are ones that they're testing out to see if the volume is there and if these are codes that are going to persist, that the technology is being used enough, and what is the volume, and do we need to move them from a category 3 to a category 1? So they test them out in category 3. So think that test technology, theirs is a 5-character alphanumeric code that ends with a T. So test technology, category 3, remember that T on the end. Official coding guidelines are also provided for CPT, and those are published by the AMA called CPT Assistant. And those also are very critical to stay up on. Then you have your HCPCS Level 2, and those have been developed by CMS. They are alphanumeric codes. They are looking at supplies and services that are not included in CPT, such as drugs, durable medical equipment, and specific supplies that impact the cost and the care of the patient. So here are some examples. Needles, MR, angiography without contrast to the abdomen, hospital observation service per hour, a heparin injection per 1,000 units, contrast material that may be used like for radiology procedure, that type of thing. And oh, let me back up. And this is where you get the codes that are often used in the charge master for these things. If you've ever heard of a facility charge master, they're utilizing these codes a lot of times for drugs and supplies and things like that when they can be billed. So HCPCS coding advice, where does it come from? AHA, the Central Office on HCPCS. They have AHA Coding Clinic for HCPCS that provides that expert advice. And again, that's something that you really need to stay up on if this is where you're at and what you're doing with your job. This is the only official resource for HCPCS Level 2 reporting requirements. Risk adjustment coding. Have you heard about that? Risk adjustment coding, HCCs. This is a relatively new model that has come out and really exploded in the last 7 years or so. CMS developed this. It's called hierarchical condition categories. Hierarchical condition categories, HCCs. They use demographic and health status to predict future healthcare expenditures. And they use ICD-10-CM diagnosis codes to determine the patient's health status. And how they do it is different than DRGs or APCs. So just be aware of that. And not only has HCC grown and developed, but you now have third-party payers that are jumping on the bandwagon and trying to use it too. So as always, Medicare starts something and they do a pilot project and then they start implementing it without penalties, and then they start implementing it with penalties, and then you have the others and other insurance companies and payers that jump on board and start using it too. They may use it the same, they may use it a little bit differently. It will depend. Risk adjustment coding. Okay, so at the start of the calendar year, patients are treated by physicians as the year goes by. Documentation's coded, the HCCs are identified. So let's say you have a perfectly healthy patient. They may not have any HCCs, or they may have only 1 or 2. Then you may have somebody with chronic comorbid conditions. They have to be monitored on a quarterly basis or a monthly basis because of their situation. Those ICD-10 CM codes are HCCs. Those are identified, and those should be being reported. And then the health is established based on those HCCs that were reported. Then CMS identifies, okay, the patient has these HCCs, and this is how it plays out in their system. They set the payment rate for the next year based on that. So if you don't code any HCCs this year, next year, when your payment rate comes through for your patients, it's going to be a lot less than a practice that is coding and reporting their HCCs on their patients this year. Their payment's going to be higher because the patient has these HCCs that have been reported. Risk adjustment coding. You need high quality provider documentation. Doesn't matter what type of coding you're talking about, whether you're talking risk adjustment, inpatient, outpatient, ICD-10, CPT, HCPCS, HCCs, it doesn't it doesn't matter. You need high quality provider documentation in every circumstance to get the most accurate code that reflects the patient's true condition and their needs. So make sure that when you're talking about risk adjustment coding and you're working, if you happen to end up working in that field, documentation by the provider is crucial. Accurate, consistent, clear provider documentation, that is just absolutely necessary, or you won't be able to be successful with coding. Well-trained coders, yes, those of you who have been doing coding or become very proficient at it, go into those risk adjustment coder positions where you're looking to see, is the doctor giving you everything they need to in terms of documentation, and is that documentation something that can translate into risk adjustment? And then it talks about figure 2.5 case study for HCC documentation and coding in your textbook and refers you to there. I'm going to stop the video at this point. I'm going to come back and do the last 6 slides in just a minute, but that will be a separate video. But I'm going to stop here because this is the bulk of chapter 2 that we're going to go through in the next couple of weeks. And that way you can have this information. I hope you're doing well. I look forward to talking to you again soon. Take care.